Good afternoon and welcome to today's webinar, 2019 Novel Coronavirus, Legal Preparedness and Public Health Response Efforts, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Trong, the Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. A quick note that both the presentation slides and video playback for this webinar will be available on our website shortly after the conclusion of this event. We strongly encourage attendee participation and would love to hear from you, so feel free to submit your questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select All Panelists from the drop-down menu, and send us your question. We will address them at the end of the event during the Q&A session. Your moderator for today's webinar is Kayleen Claridge. Kayleen is the Marketing and Membership Manager here at the Network's National Office, where she assists in the development and execution of our national marketing and communications strategy, as well as the Network's membership program. Prior to joining the Network, Kayleen worked for a nonprofit association management firm where she assisted nonprofit scientific associations in the marketing of their memberships, annual meetings, programs, and services. Kayleen will be leading us through the rest of today's webinar, so Kayleen, over to you.
Thank you, Charles. At this time, I'd like to introduce our presenter for today. James G. Hodge, Jr. is the Director of the Network's Western Region Office. He is the Peter Hewitt Foundation Professor of Public Health Law and Ethics and Director of the Center for Public Health Law and Policy at the Sandra Day O'Connor College of Law at Arizona State University. Through scholarship, teaching, and projects, Professor Hodge delves into multiple areas of health law, public health law, global health law, ethics, and human rights. His current work focuses on emergency legal preparedness and response, vaccinations, preemption, emerging infectious diseases, and constitutional rights and structural principles. So, James, I will hand it off to you.
Kayleen, Charles, thank you so much. It's really a pleasure to be able to join everybody today. I'm very delighted, without further ado, to walk us through some of the key sensational developments around this outcome or this potential pandemic, of which many public health officials globally and in the United States are starting to recognize for what it is as a potential very serious threat. So without further ado, let me give you a couple of things I'd love to at least set the parameters for in the course of our webinar. First of all, the information you're going to see me present today will be already within 24 hours dated because this is moving that fast. So some of the epi and other data that we'll go over here in just a second, just to note, we're keeping regular track of, and you'll see in updated versions of our primer that appear on the network website. And second, like Kayleen was saying, please have those questions ready for me. I'm going to go through a lot of material in quick order so that we get a lot of good points across. But what we're really looking forward to are receiving your questions and trying to answer those in real time to the fullest degree we possibly can. So without further ado, let's jump right into it. Here's what I hope we can discuss and convey over the course of the next 20 to 25 minutes, and then taking those questions from you in real time. I'll give you a brief overview. Where do we stand in relation to the novel coronavirus global spread that's occurring as we speak? We'll talk then very quickly, of course, about some of what we're seeing at the international level. I want to just make sure you're primed on how WHO, the World Health Organization, has responded, what are foreign governments doing in relation to it. And this is obviously a moving target with a lot of updates coming in, streaming in every day. We'll hone our attention considerably more to U.S. legal preparedness and response. How are federal, state, local authorities working in real time to respond to the situation around them with real data and the best available information we have. And we'll talk about some additional resources that are available post-webinar that you can turn to routinely and regularly for the purposes of updates as well. So this slide you're seeing, slide 7, is very important to note. The data that you have on screen has already changed in the last 24 hours. For example, in relation to global confirmed cases, it's not 24,000, it's in excess of 28,000. Deaths now emanating largely from China that you'll see in some additional information now exceed in excess of 560. It's still counting, and when you run the numbers as a mortality rate in regards to this novel coronavirus, or n-CoV, as I may refer to throughout the course of our webinar, the mortality rate is somewhere in the range of 2%. That's serious. That's the type of mortality rate that when you have a disease that could be spread and transmitted through multiple different means fairly easily, much like you might see with flu, that becomes very serious, obviously. Transmission is occurring in multiple different countries in domestic cases. It's occurring through multiple routes, so it's obvious that there's respiratory transmission. It is looking more and more like there may be vertical transmission, mother to child. We're looking at that extensively through epi-related issues. The R-naught number for what you're seeing with nCoV is estimated at 2.2. If so, that's similar to what you might see with a sort of annualized influenza outbreak. Symptoms, they're the ones that typically accompany a lot of what you see with these type of coronaviruses. Respiratory-related issues, fever, cough, breathing difficulties, aches and pains. These are difficult symptoms to diagnose in real time because they come on slowly and they don't manifest themselves among all cases that might actually be capable of transmitting the condition. So that asymptomatic transmission is something we're looking at globally, and here in the United States through multiple different public health scientists trying to assess, is that entirely possible? We're getting close to that. The severe cases are approximating in China, at least from what we're seeing, around 20%. So of the thousands of people infected already in China, 80% of them are just handling the symptoms relatively well, but 20% require considerably more significant medical intervention, some of which they may or may not be getting in the crisis situation there. And as we noted, death is imminent for 2% of cases at this present time. There's no vaccine. There's no commercial test. There's no specific treatment that we've identified to date. Those are forthcoming in regards to each one of those developments, vaccines, tests, as well as treatments, as currently, though, not available. This particular chart you're seeing just shows you the beginning of what WHO is concerned about, a pandemic. So it's the number of cases over a very short period of time, literally 2 weeks, from a handful of known confirmed cases to literally tens of thousands. And suspected cases are virtually in excess of what we're seeing in confirmations. What's neat about this particular curve is the top line of what you're seeing, the yellow curve, is cases known in China, and the bottom curve is cases known elsewhere in other parts of the world. Expect that curve to change quite a bit over the next several weeks ahead. The spread of the condition with the red dots on your screen here across the globe has become profound. It is a fascinating thing to obviously see so much activity within Asia and China and other parts, but to be sure, also interesting that so far 2 major continents, Africa and South America, look to be unscathed. Again, I would not project that for much longer in regards to actual cases now. What's interesting about the actual countries that we've been able to confirm so far, with good epidemiologic evidence of having actual domestic cases, is just look at the variety of the countries. Some of these are low to middle to high income countries. Some have extensive, voluminous populations, and some less so. It's spreading in different ways in different locales through various different global transportation routes, and to be sure, when it arrives, it has the potential to be spread further, absent significant interventions. That's why you're seeing international legal responses are so profound in regards to how we actually are addressing this specific condition. Now listen, in a post-SARS environment where you saw China be criticized globally for quite some time in regards to how they handled SARS decades ago, obviously the focus on China about how they're handling this specific condition is profound. And some of the things that we're seeing coming out of what and how China has responded to this, without question, are starting to establish, clear evidence of human rights related concerns and issues. And nevertheless, what you're also seeing is a seriousness that China has put in regards to how they are prepared to respond to this, including shutting down entire cities, literally putting tens of millions of people in some level of sort of temporary stay-at-home lockdown type of conditions, not allowing them to travel outside of the arena. These are profound, specific responses really emanating from the seriousness of which China has taken in regards to it. WHO's responses have been profound as well. So you saw early on they were getting initial information. It was December 31st when they got the sort of first clue from China that there actually might be an unknown etiology to this particular one condition that was reported out of, obviously, that major industrial center in China. We started to see other cases percolate in other places. WHO starts to take things very seriously, convenes its emergency committee on January 22nd, and decides a day later not to declare an emergency declaration on a global scale. It quickly reconvened that committee, as we know. And on January 30th, just days ago, obviously, WHO reconvenes its committee and declares a public health emergency of international concern. That's a smart move for a lot of reasons. First of all, recognize that's exactly what the international health regulations were rebuilt post-SARS to address, this exact type of condition. And so what you're seeing WHO respond with that public health emergency of international purposes here that's so essential are the types of things that it's expecting member countries to do. Now, WHO does not, pursuant to the international health regulations, hold a heavy hand over the course of how individual sovereign nations may respond. But the guidance is worth noting, and the attention that member states give to the IHRs following these types of efforts are well worth attending to. The expectation of organized responses, the need for critical data sharing, the efforts focused on reducing human infection and preventing secondary transmission, how we're going to communicate across global borders, the restriction of movement, when that's lawful, when it's legitimate, when you need to do it. WHO has guidance within the IHRs to address that. It sets forth specific travel recommendations. WHO's recommendations are intended to be taken under guidance and consideration. You're seeing discrimination-related issuance and guidance from WHO, and as well as calls and pleas for developing countries to be, really brought into the fold in regards to specific interventions, as well as at the bottom of the screen, pure justification. WHO expects any additional health measures that are taken to actually have legitimacy and justification for the intervention itself. Now, what you're seeing in response to the WHO Declaration of Emergency is without doubt additional emergency declarations among multiple countries. You're going to see more in the very near future. What we do know is 19 Chinese provinces are at the highest level of public health emergency declaration of the 23 Chinese provinces, literally most of the country under that sort of level of public health emergency. You saw Hong Kong, as an autonomous state, issue its own state of emergency on January 25th. Italy followed suit the 31st, and then another another province within India issuing a similar emergency declaration. We track these very closely within the network and globally for a reason. These change the game. These are legal declarations that make differences in regards to what's legally authorized or not. We'll continue to see some of this activity globally. You're seeing calls for international coordination at high levels. So a great piece out of JAMA just recently by colleagues of ours at Georgetown at the O'Neill Institute make a very significant plea for international coordination and cooperation. G7 health officials have met very recently with health ministers from multiple countries getting together to literally discuss how do we coordinate in real time our responses globally across the epidemic. These are critical facets and they're underway. You're also seeing the type of implementations that are predictable. We've seen them with Ebola. We've seen them with SARS. We're seeing them all over again. Border restrictions, travel restrictions, sort of emanating from partners close to China and others well beyond. Some of the least responsible efforts you're seeing are just the pure border closures or the pure, absolute flight restrictions that are in place in several different countries. It's a neat phenomenon that you saw Canadian authorities actually elect, as per the bottom of the page here, not to impose explicit travel bans, notwithstanding their experience in Toronto with SARS so many years ago. Interesting development. Many of these specific travel restrictions are contrary to WHO guidance, as I'll explain momentarily. This is a development that you're seeing internationally. It's going to show up in the United States very soon, if not already, as you're seeing some media accounts. Discriminatory responses to what you're seeing in relation to the spread of this from China and from other places. These are predictable. We see these consistently in regards to pandemics of this nature. This is part of the biggest facet of any emergency response is how we can clamp down and stop these types of discriminatory and literally false type of responses that you see happen across the regions. So to be sure, one thing we're tracking in the United States is just how far these specific type of discriminatory efforts may exceed literally the risk of the disease itself. Let's hone in on U.S. legal response efforts. So this got interesting very fast in the United States over the last 2 weeks for good reason. This country is taking very seriously this threat, and to be sure, you're seeing federal, state officials take very affirmative responses. President Trump has issued multiple different statements in relation to n-CoV from almost its inception. Many of these are very responsible, just trying to assure Americans. That's what you're seeing at the very beginning of some of his earliest tweets, and at the very end, of course, statements from the State of Union address just the other day. But the sense that we are under control in relation to n-CoV, that our experts are extraordinary, this is true, CDC, FDA, NIH officials, HHS colleagues, all extraordinary in regards to their capacity to respond. The President has announced the formation of a n-CoV task force, but he's also made statements that are a little bit concerning. For example, his statement on February 2nd, we're pretty much shutting down travel coming in from China. This is something that you're seeing with the State Department recommendations for the reason that we can't have thousands of people coming in who may have this problem, as the President describes. It's his statement that you're seeing at the bottom of the screen in regards to his State of the Union address the other night that really is interesting when he suggests, my administration will take all necessary steps to safeguard persons from this specific threat. That's a fascinating statement. I think we're about to see just how far that may go in regards to what the administration may do. We've seen calls for early HHS to issue a state of emergency. And to be sure, what you saw on January 31st, the day after WHO issued its public health emergency of international concern, you saw Secretary Alex Azar at HHS, who solely possesses the authority to issue a public health emergency at the national level in the United States, do exactly that. That declaration of public health emergency is something that you're seeing in regards to how it's changing the game already legally for what and how we respond, and through federal and state partners. So, for example, HHS public health emergency powers, not all of which have been invoked yet, but could be in the near future, has the capacity to free up federal resources. Without question, has the capacity to encourage interjurisdictional coordination. It can allow waivers of specific federal laws, not all, but some. And it authorizes real-time countermeasures through emergency use authorization through FDA. We'll see about that in a second. And it can support social distancing measures. These are the types of powers available now through federal intervention, thanks to the Secretary's issuance of a public health emergency. How these powers are wielded gets interesting. All of the federal agencies you're seeing on screen here in slide 25 all have a role to play, if not already, or soon will, in response to what you're seeing in regards to this potential outbreak. CDC, obviously, as the nation's leading public health authority, has had very profound and very extensive responses already. And while this little timeline just gives you a sense of some of what CDC is up to, obviously it's gotten considerable national and global attention in regards to implementation of its quarantine powers in an almost unprecedented way, as CDC officials themselves describe, in regards to flights coming back from parts of China, literally commissioned by the CDC or the State Department for the purposes of bringing Americans back and others. So we'll see a little bit more of just how far that may go in just a moment. FDA's got a role to play. In fact, one of the most critical is its capacity to issue what we call emergency use authorizations. And this is a neat intervention explained as simply as follows. During these types of public health emergencies, FDA can actually approve products that have not been fully market tested or gone through every last level of FDA review if they could be effective countermeasures that may respond in real time. And that's exactly what it did just the other day. The FDA did grant an emergency use authorization for CDC's n-CoV real-time PCR test. That's valuable and important. You're going to see potential other EUAs issued, I dare say, for everything from prospective early vaccines to no medical treatments that may work. The U.S. cases of n-CoV right now are a handful, as we know. We have one of the earliest cases actually right here in downtown, or in Phoenix, in Maricopa County, one of the earliest, but you're seeing, of course, more cases percolate from the initial one in Everett, Washington, to additional ones in California, Boston, and as you know, one that just occurred in regards to full testing through CDC in Wisconsin just last evening. So to be sure, how many of states will have cases in the near future? I'm not making predictions, but I will say there are hundreds of suspected cases, to be sure. CDC's looking into testing all of those through its capacities in Atlanta. These are the types of emerging legal issues to be keeping our eyes on. These are the things through experience that we know are going to arise as critical core question areas. We're going to be looking at and assessing what's the scope of emergency powers. What sort of testing, screening, and treatment initiatives can we use? What type of travel restrictions are we prepared to implement in the United States or between states? What social distancing measures are available to us? When can we use these lawfully and effectively? What about surveillance and reporting? Are we upgrading and ramping up those specific efforts? There are profound privacy implications that arise from these types of events. And to be sure, there's liability and insurance-related concerns that are already starting to crop up. I'm going to take just a few of those observations from that last slide and just show you a little bit of what to expect in regards to some of these key powers. First of all, emergencies. Hey, you know we're in a national public health emergency as we speak. How long will it be before states and localities declare their own type of emergency? I'm not thinking too long, but we haven't seen any development to that effect yet. Do let us know through the network if you're aware of it. But to be sure, what we're talking about here is exactly what we work to address in regards to how we clarify a public health emergency post 9/11. So what we experienced post 9/11 with the anthrax exposures led to a reformation of how we conceive of what a public health emergency is. And among most of the states that have sort of adopted provisions of what we call the Model State Emergency Health Powers Act, I think you'll see a lot of those states and localities with that legitimate authority issuing some states of emergency should cases sort of arise and continue in the United States. What would those emergency authorizations or declarations do? Does some really neat stuff in real time. It's sort of like snapping your fingers and realizing what you couldn't do before, you can do now, thanks to the emergency declaration. Governments vested with specific expedited powers to facilitate emergency responses. Individuals are given special protections, special entitlements, things they wouldn't get normally without cost. They might get during the course of an emergency for the community's health and for their own health protection. Emergency responders, volunteers, others might be protected from civil liability for specific acts, if but to encourage them to respond in real time. And normal procedures and practices can effectively be waived in some circumstances. Things like in-state licensure and other privileging requirements, other necessities to eliminate barriers to emergency response can be dealt with in real time only for the course of the duration of the emergency. We shall see how many states follow suit with that like the federal government has. We are also in that state of shifting to crisis standards of care. Now, this is what you're seeing happen in China right now. They have shifted to crisis standards. They're overwhelmed in multiple different facilities. Hospitals are completely filled up. They've literally built new facilities in Wuhan, China to accommodate this sort of influx of patients and need. They've shipped thousands of healthcare workers to specific affected regions. That's crisis standards of care time. This is what the National Academies of Medicine talks about in regards to how to implement crisis standards. So many states have done excellent planning. CDC's thought these issues through. But to be sure, this is happening, or will happen very soon in the United States, should we see influx of new cases. What's actually available to us from a public health perspective from regards to a social distancing measure? Here's how critical these observations are. We have no known vaccine, no cure, no treatment of a condition that can spread relatively easily, person to person, with other types of spreading opportunities that are yet to be known. So what do you have available to you from a public health perspective? You've got these types of powers, the powers to implement things that actually make sense, done within ethical norms and consistent with principles of voluntarism. These powers are known through good study to work really well in response to emergency issues. How you actually restrict travel, control modes of transportation, increase distance among people for specific reasons. The power to dismiss schools or restrict public gatherings, to implement isolation and quarantine or evacuation measures, or even issue curfews under limited circumstances. These are the types of powers available to public health authorities. How we use them effectively and lawfully is greatly dependent still upon constitutional norms, freedom of religion principles, equal protection concerns, freedom of movement against rights or restrictions of rights to travel, privacy implications, First Amendment rights to assemble. These all and other rights get implicated in the response to how we actually do these types of social distancing powers in real time. I don't think there's a more profound illustration of this than what you're seeing right now at the federal level. So you saw literally just a week ago or so, you saw several senators briefed after federal officials sat down with them on January 24th, basically seeking more information about incoming travel restrictions, calling for more, and yet being told by initially federal health authorities that's really not quite necessary. In fact, one of the great colleagues globally or nationally working on these issues, Dr. Tony Fauci, actually at NIH said, frankly, after a briefing with senators, it's really not something in regards to travel restrictions that we're even considering at this point in time. But a week later, January 31st, Trump administration does issue a very significant sweeping ban of foreign national travel for those who have been in China within the last 14 days and might pose a risk to Americans, to the public health of the country. These are, again, profound responses in relation to just what is possible through federal authorities for the purposes of restricting travel to the benefit or to the goal of actually addressing the public health repercussions. But when and where those travel bans can work actually efficaciously is yet to be determined in regards to whether or not that's smart public health policy is something we will begin to see. Whether it can be constitutionally challenged is also something we're very closely watching to see what type of challenges may emerge from it. Quarantine and isolation is getting a lot of attention for good reason. Let's just make sure we're on the same page legally about the difference. Quarantine. So when you separate from others, people who may have been exposed to a contagious condition prior to knowing if they're ill or contagious with it. So you were exposed to it, but we don't know if you're going to come down with nCoV. We're going to actually separate you for a brief period of time. And then there's isolation. We know you're infected. We're going to separate those persons who are known to be infected with a contagious condition like nCoV from others just to make sure it doesn't spread. So these two powers are quite critical and can be used very effectively if done lawfully and within principles of core ethics. It kind of looks like this, as you know. I mean, with quarantine, you're talking about some level of separation between sort of the yellow individuals exposed to contagious disease versus healthy persons, and on the right side of your screen, the isolation cases. We take those red dots, those known index cases, and we isolate them for a period of time. And along the way, provide effective treatment to the degree we can, monitoring, and other specific conditions that make that isolation as beneficial for the individual as possible. These types of concerns in implementing these types of social distancing measures do arise. These are restricting on civil liberties at times, obviously, and so the issues of practicality and timing do come up. When is it practical to implement quarantine measures? What is the right time to implement those measures? What's your factual justification for doing so? Do you have sufficient basis to believe these persons were exposed to nCoV, and under those circumstances, you may be able to proceed from a federal, state, local authority on a quarantine or an isolation initiative. Constitutional protections do not go away during the course of these emergency events. People are owed and entitled specific constitutional protection, particularly under due process, like procedural due process norms. They don't go away, and you have to adhere to them to the fullest degree you can in real time. There's authorities, enforcement. What if somebody breaches quarantine? What's allowed? What's lawful? Be delighted to take questions related to that. And then the sheer feasibility of it all. What's possible? How do we actually feasibly incorporate quarantine measures, isolation measures, not just among a dozen or so cases we might see in the United States, but should this expand to hundreds or regrettably thousands of cases in the U.S., would we continue to proceed with these same initiatives? That legally becomes very interesting very fast. So the types of settings you're looking at here, gosh, routine quarantine is done all the time in the United States, and it's done with good due process. It's done consistent with equal protection rights, similar treatment for like individuals, one of the standards of how you actually implement these measures effectively. In a declared emergency, sometimes we can not bypass those specific interests, but we can do expedited efforts and powers so long as they're still respectful of these constitutional principles, and sometimes back it up with the appropriate due process and into and after the impact of the specific isolation or quarantine measure. It's what you're seeing in the media right now that garners a lot of attention. And it's really quite profound, because what you're seeing happen in the United States in unprecedented ways, as literally CDC officials have described, is you're seeing a federal implementation of its sort of newly found quarantine authorities that were rewritten into federal regulations in the last 3 to 4 years at the very tail end of President Obama's administration. CDC, through Dr. Redfield, using its own quarantine and isolation authority to basically route flights coming in from Wuhan, China, and other places to specific military bases that have been approved by the Department of Defense, set aside for quarantine of persons that are on those flights because they very likely could have been exposed to the coronavirus. That's unprecedented. This has not been done by CDC in the modern era. And yet what you're seeing already are a single flight in California already routed and several others on the way. In fact, one was rerouted from its landing in Las Vegas to Los Angeles just the other day for the purposes of assessing the specific risks there. Contrast that on the other side of the screen with what you're seeing at state and local levels, and that incurs, thousands of Americans potentially that have returned from China or other affected regions that are basically under quarantine orders to stay at home, to self-administer for their own symptoms and own conditions. This sort of home quarantine initiative that state and local governments use regularly, routinely in the United States, can be very efficacious. They can work. It actually can be a preferred technique. It's considerably less expensive, and while it doesn't serve as a foolproof effort for the purposes of quarantine, it generally has great efficacy. It's a fascinating legal assessment to know that both of these types of quarantine are at work in the United States for the same condition, depending on which government basically your order or those orders flow from. We'll discuss in more detail for questions for purposes of what might be legal issues related to this, but it's a fascinating observation. You're also seeing screenings being occurred at U.S. airports extensively, and this is under CDC guidance as well. Extensive screenings of incoming passengers, specifically from affected regions, really just to make sure we don't immediately see cases that might be actual known cases for isolation or at least suspected cases for quarantine. Hey, these screenings, as per a great report by my colleague Leila Barraza and others published by the National Academies, lays out neatly how you can effectively, lawfully, and ethically do screenings and other initiatives through U.S. airports for this purpose. But to be sure, it's not foolproof. In no way, shape, or form do we expect that these screenings catch all cases, obviously, in coming to the country. And finally, just a brief note about surveillance and reporting. This is happening across the United States. We're actually expecting and asking for healthcare workers and others to report in real time, like instantly, the moment they think they may have a suspected case of n-CoV. And those test results are going to Atlanta for testing, sadly, which still takes, hours or days sometimes, instead of mere hours as a commercial test may be able to provide soon. What's interesting in Ohio that you see here is its immediate request or classification of n-CoV as a Class A condition for immediate reporting, and its assessment that physicians, hospital administrators, and others would report, but also, at the bottom of your screen, any individual having knowledge of a person with n-CoV. Now, that sounds responsible and very well may replicate a lot of what you see in reporting statutes or across the United States, but this idea that even, a person without healthcare-related knowledge might be able to report those cases or should be reporting those cases. It gets interesting from a privacy perspective. There is so much more information about what I've discussed, all available on our network website, and so many of our great partners across the country in regards to how we're responding responsibly. Check it out at the network website. My special thanks to colleagues Leila Barraza, two of our fantastic students here at Arizona State University School of Law, Erica White and Claudia Reeves, for their contributions. Ask the network about anything you would like in relation to these issues. We'll try to get you answers in real time. Without further ado, let's see what sorts of questions have arisen in regards to the types of observations we've made so far. I'll turn it back over to Kayleen for additional questions and thoughts. Kayleen?
Yes, James, we've had several questions come in. We'll start with this one. What are the limits on the ability to curtail individual liberties?
That is such a great question because we are absolutely figuring those out in real time. But let's focus on the sheer observations of what the possible limits may be. First of all, if you have been exposed to n-CoV, any federal, state, local public health authority will tell you, that's a legitimate concern for the public's health, and we obviously want to clamp down on this condition of a contagious nature, much like many other conditions. But because of the sheer emerging nature of it, the newness of it, and the opportunity to potentially clamp down on it sufficiently to prevent its widespread across the U.S. population, there are certain restrictions that could be lawfully put into place, many of which will not be necessary so long as individuals voluntarily comply with home quarantine or other type of initiatives. You're seeing that 14-day period be recommended by CDC for that purpose because it could very well take that long for clearing a patient, even that one that was exposed, right at the beginning or inception of a quarantine measure. Clearing them completely of infection is, of course, the idea. So we know they couldn't affect others. That type of home quarantine order that's being replicated across states and localities is legit, and it's there to protect the individual as well as populations. That's the type of infringement of individual sort of expectation of travel or liberty of movement that is lawful and legitimate, being used effectively. More serious quarantine measures certainly do raise very interesting questions. I'm going to offer one interesting observation to this, and of course we'll take additional questions. I'll be brief on each one of those. But the interesting observation is, at every moment in regards to the implementation of quarantine measures, we seek legally to do what's the least restrictive infringement possible that will still work for the purposes of assuring the public's health. But by least restrictive alternatives, we're talking about the ways in which you can implement social distancing that is at least restrictive on individual liberties and norms as possible. So if home quarantine works, and that's less restrictive than bringing you, for example, to a military base, there's at least good reason to think that's what lawfully should be prescribed. It's not currently being done by CDC in several different examples, and it may be an interesting challenge down the road that we shall see as to whether or not that type of separate quarantine at a separate facility, literally, holding persons off at a different facility for a period of time as we are currently, whether that's absolutely essential or represents the least restrictive alternative. It'll be a very neat question for us to resolve in real time in the United States in the next several weeks ahead. So, Caitlin, go ahead. What other questions?
Sure. Is there any published guidance on the involvement of law enforcement and efforts around isolation and quarantine? We are not at that stage, but planning ahead if need be.
Oh, neat question for sure. And without doubt, law enforcement has a role to play with this only if you're dealing with persons who seem unwilling to participate voluntarily in quarantine or isolation measures. So we saw some limited issues related to this, for example, the Ebola scare from 2014-2015. We saw limited need for law enforcement to step in and at least protect the circumstances around the movement of a patient or assure that a particular patient or persons around him or her may have had sufficient protection, healthcare workers and others. The truth is law enforcement can be very helpful for providing the sort of backup and protection necessary to assure that we are focused on something which is non-criminal in nature, that is quarantine or isolation. These are not punitive measures. It's only breaching quarantine or isolation where punitive measures come into play. Implementing them may only require law enforcement in many ways for the purposes of assuring the protection of persons around the situation, but working hand in hand with state and local law enforcement in your community is smart now so that they understand and expect how their role may play out in regards to implementing and assisting public health authorities. It's a smart question to start working on as we speak, if but to make sure there aren't misunderstandings and missteps about how to coordinate those efforts.
Does the fiscal responsibility of local and state authorities depend on the degree of quarantine and isolation, the resources of the person being isolated, quarantined, or both?
Wow, good question, and I love it. Here's how best it works in regards to what you might see at the federal level, and then I'll extrapolate from that some local and state observations. So first of all, at the federal level, you're seeing persons under quarantine right now. And under those federal rules I mentioned earlier, revised in 2017, CDC has to provide the necessary sort of essential care, essential treatment, testing, and all of that at CDC cost, unless private insurance could pay. We don't know among the persons quarantined currently whether or not they have private insurance that might pay for some of those services, but we do know, written within the rules, is the capacity for CDC at least to seek that for purposes down the road of compensation or at least reimbursement. But listen, when you're at the state or local level, in regards to how to best implement quarantine and isolation, it starts with the notion that you're going from a state and local perspective to have to cover the cost of effectively doing that in real time. If a person's under a home quarantine measure, that's state and local government monitoring for that person who's meeting their own costs in relation to their own treatment regimens or otherwise. But if you need to test them, obviously, in most cases, you're not charging those persons directly for testing them for the purposes of assessing whether or not they pose a real risk. That's on public health authorities to do in most jurisdictions, in most situations. There is, of course, a plea for a resource infusion from the federal government. Multiple congresspersons are making this plea. You're seeing considerable effort towards freeing up hundreds of millions of dollars for this purpose. The Gates Foundation is putting in hundreds of millions into global response efforts. The important observation here is the best way to protect the public's health is to assure when you need compliance and adherence to state or local quarantine measures, you cover the cost of what you need from a public health perspective and defer the cost for what a person may choose to do in regards to their own specific at-home type of treatment. I hope that helps a little bit to respond to that. There's a deeper level to that question, and then at least give an initial early response. Caitlin, go ahead.
What should state health authorities do to help prepare the state judicial branch to respond to an isolation or quarantine request?
Nice question. Love it. So listen, there will be cases arise very soon. We're predicting it. We're monitoring for it in the western region of the network. We're looking at it closely. Cases that actually start to emanate out of jurisdictions challenging or questioning the need for quarantine or isolation. It could be public health authorities at state or local levels are bringing these cases before judges because they want a quarantine order that they're required to implement through judicial action. Or the quarantine orders or isolation orders are challenged by individuals. So these types of cases will arise. What's your best way to prepare for it? Hey, judges in any specific setting to be able to effectively respond in real time with really good guidance need to kind of understand now what are the limits and extent of abilities at the public health level for implementation of these type of social distancing and other measures. These are spelled out well in most jurisdictions. I mean, they really are. They're spelled out. Public health authorities are smart. They know how to implement these things, but sometimes judges haven't seen these types of cases. They may not fully understand and appreciate what it means to set the sort of justification for quarantine or what a least restrictive alternative might be. That real-time guidance and training that can make a huge difference for how best a judicial intervention can work well for protecting the public's health. And to be sure, we're all in it together in that regard. That comment's merely meant to say the overriding objective against the backdrop of any emerging infectious disease is to protect the public's health in a way that's constitutionally sound and in a way that's respectful of individual rights and norms. That's how we do it well. Judges play a big role with that, and it may start to come up in jurisdictions across the country. Go ahead.
The Department of Homeland Security, not CDC, on February 2nd announced mandatory quarantine measures for returning travelers. What is the legal basis for this, as it must be implemented and enforced by state and local governments, as you noted?
Yeah, neat question and point. So to be sure, DHS actually is something, at least in some early reports, is something of an advocate of the home quarantine route because it knows as thousands of cases potentially emerge in the United States, and I don't mean known infections, I just mean suspected exposures. As thousands of these cases, come back from affected regions, virtually every continent soon will have, known cases, so it's literally everybody traveling in from everywhere coming back to the United States that might at some point become an interesting person of under investigation or otherwise. I think what DHS is merely trying to say is, pursuant to our national public health emergency and pursuant to the abilities and controls of which we could implement at the federal level but would be deferential in that interjurisdictional coordinative type of way to state and local authorities, who are the original holders of public health powers in our whole constitutional design, hey, federal officials are deferential to state and local governments actually implementing these types of quarantine and isolation measures. And so they should be. It's too big of an issue that even for the federal government to absorb completely. So I think how you actually take that in is you recognize what DHS is trying to say is that these reasonable measures implemented effectively, consistently, as I've noted throughout our discussion, with individual respect for rights and voluntarism at the core, these specific measures implemented at the state and local level will make a big difference in relation to how we respond in real time and potentially limit the exposure and spread of the condition in and of itself. So I think what you're seeing are state and local governments that will respond in kind to that specific order from DHS and implement the type of home quarantine measures that you saw in Toronto during SARS and we'll see in the United States in regards to this specific outbreak as well. Go ahead.
What guidance should local health departments be looking towards for home quarantine persons with the assigned CDC medium risk that may be non-compliant? We are planning for guidance for monitoring these self-quarantined individuals, however, not prepared for non-compliance actions that may be necessary.
Yeah, neat. What a great question. The non-compliance issues are going to be there, unfortunately, among a few cases and persons. And I predict that because most people already, as you saw for one of the slides, they're self-administering their own home quarantine. They're alerting health authorities of their potential exposure, but they're self-administering and or being monitored, as you saw in some of the early cases in Washington and such, by really dedicated health officials doing their best. But here's what it boils down to. CDC's put out, as usual, outstanding guidance about some of this specific information. And what and how you actually self-monitor in a quarantine-related setting through state and local government is something that's pretty well illustrated in some of the CDC guidance. What do you do against the backdrop of the non-compliant case? What's lawful? What can be done? That's where things can get serious. I mean, obviously, against the backdrop of a known infectious disease, which does have a fairly high mortality rate compared to other conditions like it, if you have a non-compliant case, state and local authorities do have the capacity, legally, to intervene in a more aggressive way. They don't want to have to, obviously. It's going to be time-consuming. It's going to be contested. There are going to be courts involved, and there's going to be a real need to identify specific resources and or places for persons who, seek not to engage in the typical home quarantine order to be placed temporarily for that purpose. But it is a power that public health holds at the state and local level. I think you'll see some additional guidance for how to do it effectively, but legally we're talking about respect for individual liberties, but that respect stops at the moment that that person may be exposing others, either by their own knowledge or just in a way that could be reckless, to this specific condition. So a neat, pithy way to state it might be as follows. State and local authorities can get tough when they need to in relation to non-compliant cases. I don't expect they'll have to in most instances, but when they do, courts will be involved. There will be sort of assessments of the real risks of the particular person, and that's where law enforcement may get involved as well for the purposes of assuring the protection of everybody around the case itself. I hope that gives a little primer, but I'd be happy to go into more detail on that in a separate discussion as well. Go ahead, Kayleen.
I've always understood that public health authority stems from state-based police powers, though I understand that the federal government may have authority in the case of interstate travel. Does federal public health authority extend to persons within a given state?
Oh, great question. I love it. Gosh, such smart observations, and the reason for it is exactly what and how CDC revised its rules in 2017 to accommodate that precise issue. So yeah, CDC has the power, pursuant to these new rules, to quarantine what we call the foreign quarantine, the plane coming in from Wuhan, China. CDC's got it. CDC has the capacity to quarantine persons who engage in interstate travel. I flew from Kansas City to Los Angeles. CDC can intervene there. But the question's smart. Can CDC come into a specific state and say, we've got a case here, and we need to intervene, just because this person on an intrastate basis may pose some risk? Actually, a fair reading of the rules suggests it does have that capacity. So long as that person may have engaged in some sort of level of transportation, some sort of light rail system, subway system, some sort of in-state transportation, hopped a flight from Phoenix to Tucson here in Arizona, yeah, CDC can intervene in that specific circumstance as well. And while it is unlikely to do it without notifying state and local authorities, or frankly, flat out seeking state and local assistance to accomplish that goal, I see within the new rules the capacity for CDC to do exactly that. I wouldn't project that it will, absent, again, state or local acknowledgement and or assistance provided, but it's a neat observation that intrastate case might now be subject to some level of federal intervention.
To what extent can the government curtail First Amendment rights to the extent that people disseminate false information that could negatively impact the government's ability to combat an epidemic?
Great point. I could have easily brought that up. We're watching for this stuff right now. The rumors, the false data, the sort of anti-science assessment of what's out there, what the risks are, what the cures may be. This is all false, misleading data. We're seeing it percolate already, globally and in the United States. And you're seeing some very responsible social media companies actually address this by shutting some of that down, which is just a terrific development in the sort of post-anti-vax era of what we've seen in regards to some of that. But here's the sheer reality. There's no First Amendment right to spread false, misleading data on something this serious. in relation to an outbreak that could be harming thousands of Americans, you don't get, from a First Amendment perspective, to share false, misleading information. Now, let's contrast that with early, assessments or opinions about what and where specific risks may lie. Obviously, that's a little different. But if you're having commercial entities or others share, known false and misleading information that can skew or directly interfere with public health responses, I don't see a lot of First Amendment protection for that type of speech. Furthermore, I think government can find an easy way to shut that down. But again, we will very likely find ourselves in a judicial setting with judges trying to make very quick decisions about what can be done in real time. It gets a little easier when it's Facebook or Twitter or others that are making those choices. They can do that. We don't have to seek government intervention for that. Facebook can move on its own. But if government wants to intervene, we may have First Amendment challenges. But again, no First Amendment right to circulate known false or misleading information, especially against the backdrop of an emerging infectious disease.
What type of situation would require local health districts to use a hotel or alternate facility for quarantine purposes? Is this something we should consider now, and what type of guidance is available to assist with choosing quarantine locations?
Ooh, neat. So that's a great question, too, because there are right quarantine locations and there are very wrong quarantine locations. And how you best assess that within your state or local jurisdiction is very critical for that purpose. First of all, check your emerging infectious disease plans to see what's already been done. Check your crisis standard of care plans that have developed so well across so many different jurisdictions pursuant to CDC and National Academy's guidance. My bet is a lot of that may be spelled out there, but if it's not, here's a few parameters to live by. First of all, I don't know to what degree you're going to need it. I'm hoping nationally that home quarantine initiatives and Americans responding as we do rationally to these types of issues will implement and require only minimal home quarantine measures for a brief period. But to be sure, if you do need to go the route of quarantine at a separate, distinct facility, very clearly what you're after is several fronts. First of all, that facility better not create an environment that actually makes disease spread more likely than not. There's a problem in and of itself. You don't want to place 100 people in a specific facility where disease spread becomes more likely than not because of the way in which it's held. So think less about that gymnasium full of beds and more about the hotel on the outskirts of town that, maybe is fully empty and government can take it over for a brief period. And during an actual declared emergency, government can do exactly that in many states and localities. It's about also the capacity for that quarantine facility to create an environment where people are, certainly understanding, least restricted in regards to their movement, have the capacity for interventions to protect their health, have available to them the sort of modern conveniences you might imagine, in other words, access to communication, Wi-Fi, use of their cell phones. Quarantine is not about mental stigmatization or social discrimination. It's about just doing what's necessary to create an environment for a brief period that persons may find at least the opportunity to protect themselves and others from infection. To that degree, the right type of quarantine setting is one I described. The wrong type could actually draw public ire and be very difficult to actually route people to should you choose that route. Those observations, I think, from a lawful perspective are ones I would take to the bank, but to be sure, it will depend on resources available in each community.
Are there examples around the country that ensure financial support for individuals who are subject to a public health isolation or quarantine order and unable to work? For example, in situations where individuals do not have paid sick time or other benefits.
Great point. Paid sick and safe time laws across the country are fantastic for addressing something that actually in prior outbreaks of a limited nature in the United States, we always recognize as a big issue. Hey, it's not the quarantine that's the problem sometimes. It's the 2 weeks of unpaid work that a person may have to endure or the loss of a job that a person may have to, take in because they can't work at their specific locale for a 2 to 3 week period. Or the stigmatization that comes with even thinking that person might return to work and expose others and be fired for those reasons. These are untenable. They're often unlawful. And actually what you see within, for example, the Model State Emergency Health Powers Act are key provisions saying, that type of response, the loss of job, loss of pay or what have you for a quarantine-related initiative is is unacceptable and unlawful. Unfortunately, I will have to say that what you're not seeing, however, is sufficient protection that spreads evenly across all states and localities that assures those results can't happen everywhere. So while some states do have provisions very clearly in place to stop that type of issue in its tracks, in other words, people losing jobs or losing employment or all their livelihood because of this condition, they may be unprotected in other jurisdictions. We've tried to equate that. We've tried to address it systematically, but it is a consequence of sometimes these specific disease measures. It is something to be worked on and something to be looked at very closely in each state in regards to how to best set the policy. Go ahead.
Why would WHO recommend, well, the WHO, sorry, recommend against travel bans when the disease has spread so easily?
You know, that's such a great question, and what the United States has done in regards to its travel ban is without question in contravention to WHO recommendations at this point in time, and I'm going to give you a practical reason why. WHO knows from experience that travel bans can have a very significant backlash for controlling an infectious condition. And the backlash can be that it actually enthuses and encourages persons, first of all, to evade that ban, to actually engage in behaviors that the State Department and pursuant to the President's proclamation are anticipated in the United States, that people route in through ways that they can evade health authorities, that they can get past CDC screening, that they fly into Canada and cross the border into New York or something. We've seen that in the past in some famous cases in the U.S. So the sheer reality is sometimes one of the best approaches is you set up the type of regular routine monitoring and surveillance that can be done through airports, ports of entry, and other places. You set that up, you effectively implement it, you look and try to identify the cases as closely and as best as you can. But the sheer travel ban, the sheer travel restriction, is, first of all, nearly impossible to uphold. And second, how long are you going to hold that into place, and how many different continents are going to have that applied to? Very soon you might have to see the U.S. actually enter a complete travel ban because every continent might be impacted in some way, shape, or form. In other words, and neatly stated, WHO knows from experience travel bans are non-efficacious many times in relation to clamping down on a condition spread this easily, this quickly, and for these purposes. Regular surveillance, monitoring, social distancing interventions at the host site of any particular index case, that may tend to work better. I hope that helps a little bit in responding to that question.
So we have probably time for two more questions. Does the declaration of the public health emergency automatically free up strategic national stockpile inventory, or do we still have to wait for our state to declare the public health emergency?
Oh, neat question. So CDC is in control of that to some degree, and while they work very closely with federal authorities towards the strategic national stockpile, states do not, repeat, to my knowledge, do not have to declare some state of emergency to gain access to those strategic national stockpiles. It's not necessitated. It's not a condition states have to do for being eligible for receipt of those. If there are supplies within the SNS that could be distributed to states, CDC or others in charge of those decisions do not have to see a state declare a state of emergency for the receipt of that. And I hope that helps on that front. And to be sure, I'm not fully aware of where CDC may be distributing and to what states may be first receiving any initial resources, but it does not require those states to issue a state of emergency.
Okay, a final question. What provisions are in place for the homeless populations for quarantine?
Oh, gosh, that's so profound. Let's be brief in response to this because it's a dominant concern, especially perhaps in California, with its huge homeless population and, frankly, the greatest number of known cases. We have no prediction about whether that would spread systematically throughout California's dense population in Los Angeles, San Francisco, and other places. But to be sure, persons who are homeless present a very different situation. There is no home quarantine to be done that's reliable and sufficient for the purposes of protecting the public's health. That may be exactly the scenario should we see a known risk among homeless populations in specific jurisdictions, major urban areas like Los Angeles or San Francisco or San Diego. If we were to see that, I'm sure public health authorities within those jurisdictions are prepared for set-aside quarantine measures to be put into place to properly house persons without otherwise additional safe homes for the purposes of these quarantine measures. But it will get expensive and fast, and where and how federal authorities can actually help to implement those measures through specific infusions of resources, I'm sure will make a critical difference. But as far as the planning for that, it best be there. And as far as the need for it, it's quite possible. We will have to see how this disease spreads over the next several weeks to come. But I do hope these questions gave a nice sort of assessment of the types of things we're watching and following and monitoring in real time. Keep your questions coming in regards to additional observations. You can email me at the address that was on screen previously at any point in time, and we will look to try to answer those questions in real time for you.
Thank you, James, for this important and very timely information. I'm going to pass it back to Charles for some closing remarks.
Great. So thank you, everyone, for your participation in today's webinar. And again, thank you, James, for presenting today. I learned a lot, and I know our attendees did as well. So just a few final notes to all of our attendees. If you did submit a question that did not get addressed during the Q&A session, don't worry. We tally all of these questions up, and we'll be sending them to James at the end of the event. Also, all attendees will be receiving an email from the network with the video playback of this webinar, as well as a link to our brief webinar survey. The survey takes just 1 minute to fill out, and it provides us with some really great insights, especially in regards to what topics you might be interested in for future webinars. You will also be receiving an email from ASLME with information on how to apply for CLE credits for this event. If you enjoyed this webinar, be sure to check out our next webinar at the end of the month on the public charge rule and the threat to public health. CLE credits will be offered for that webinar as well. And finally, registration has opened for the 2020 Public Health Law Conference, where attendees will learn legal and policy tools to address fundamental drivers of inequity, promote health and well-being, and save lives. You won't want to miss it. That concludes today's webinar. Thank you all for attending, and have a great rest of your day.